Hi, welcome. I'm Bob McNellis. I'm Senior Advisor for Primary Care here at the Agency for Healthcare Research and Quality. And you caught me as I was looking through my version of Primary Care Research Agenda for the 90s, which in many ways was an inspiration for the meeting that we're going to be holding in just a few short weeks. Here you're going to see a couple of video clips from AHRQ's past leaders in primary care research. I interviewed Dr. Carolyn Clancy, who was at AHRQ for over 20 years, the last 10 of which she was here as the director of the agency. I interviewed Dr. Helen Burston, who led our Center for Primary Care Research in the 2000s. And we'll also interview Dr. David Lanier. Dr. Lanier most notably led our practice-based research network initiatives. I think you'll find all three of their observations interesting about the past. I actually asked them three questions for them to respond to. The first was, what would you say was the most significant accomplishment in primary care research during your time at AHRQ? I then asked them, what do you wish you would have accomplished, but you weren't able to during the time you were here? And then the third thing I asked them is, what guidance or advice would they have as we sit down in early December to develop a research agenda for the future? I think you'll find their reflections insightful. The videos are not too long. And if you hang on to the very end, I think David Lanier's guidance to us near the end of his video, I think is quite, you'll find quite interesting. So hope you enjoy them. Thanks.
Bob, it is really such a pleasure to be here and look back at this very, very rich history. And so thank you for the opportunity. Currently, I serve as the Dean of VA Healthcare, which sounds like an illustrious title. It's a tiny bit made up, but Dean is actually the acronym for my group. So I lead a group of awesome people who are involved in all of VA research, and as well as our academic affiliations program. I don't think that most people know that 70% of docs in this country actually did some training in a VA. So we're very proud of that. And we also have a group doing healthcare innovations, including a national simulation and learning center. So very, very exciting work. I started at AHRQ in late 1990. So the agency, it was then had a different name, and it was a very, very exciting place. A lot of people worked nights and weekends because they were doing new work and trying to figure out how to get it right. It was awesome and very inspiring, and people were energetic and really enthusiastic and brand new stuff. So it was a lot of fun. And part of the reason I came to AHRQ, I had been in academia before that. I was teaching at what we then called the Medical College of Virginia, which is now under the rubric of Virginia Commonwealth University, branding. And so I came to AHRQ, or what was then AHCPR, because it was the only place in the federal government that had a focus on research in primary care, which I thought was just awesome. Now, I will tell you that on more than one occasion, when I would call someone in NIH or something and say, I'm from the Center for Primary Care Research, and I would go on and the other person wasn't saying anything, and I'd kind of say what? And they'd say, I don't get this. There's primary care and then there's research. I've never heard them together before. Wow. Whereas as a primary care clinician, I'm an internist, but very passionate about primary care. I know that's where it all happens. It's really the gateway to everything else. So hugely important work.
Wow, that's terrific. Thank you for that background too. And you were to quote him, in the room where it happened. In some of these early days of AHRQ's primary care research. So, but looking back over that span, you were there for over 20 years then at AHRQ. And if you had to think about primary care research from your perspective, then what would you think of as sort of the most significant accomplishments that you reflect on that you can think of in that time you were there?
Well, looking back, I think some things we did that were really wise in retrospect. One was bringing in a lot of visiting scholars, initially in family medicine, but then in nursing and some other disciplines as well. Um, you know, because it helped bring a fresh set of eyes. It also helped us build support among various organizations that contribute to what some see as a patchwork quilt that is
Mhm.
primary care. And I mean that in a very complimentary fashion. Um, so that was one big accomplishment.
Nice.
Probably the other had to be the practice-based research networks. Hugely important. Even in VA, we still kind of struggle with this. How do we make sure that we are speaking to the needs of people on the front lines? Sometimes we get that right. A pandemic gives us the opportunity to, you know, it doesn't take long to figure out what people need to know or want to know. But other times that's very, very tricky.
Yeah. Well, that's terrific. Those are sort of really important, I think, assets that we were
Yes.
able to have by expanding the community in two different directions, academically and getting that practice-based evidence. I can see
Yeah.
why you would highlight those.
Yeah.
Well, and then think about all the things that you did. Were there some things that maybe you wish you could have done but weren't able to do, either for policy or resource reasons or just time constraints? Is there something you look back and you say, "Dang, I really wish we did this"?
Um, One thing I wanted to do, but the timing was not very good,
Yeah.
uh, working with some of my colleagues, was to have meaningful patient representatives on the Preventive Services Task Force.
Oh, interesting.
Because when I think about a lot of the work we did at AHRQ and all the changes in healthcare while I was there, what a big, big game changer is including consumers slash patients um, in the mix,
Yep.
right? If you think about quality and safety discussions where people get excited about possibilities, and invariably the practitioners kind of say, whoa, whoa, wait a minute, we can't go that fast. It's too
Mhm.
important not to get it right. It really helps to have someone else in the room saying, can we just say that again? You're telling me so and so has done a study which shows that if we do X, we will save lives. And you're telling me we got to wait?
Mm.
You know, that's, and I mean that in a very positive way, that, you know, kind of constructive tension can actually spur and motivate action, which I think is really phenomenal. If there's one thing I wished we did differently, it was giving more voice to patients.
Mhm.
Since I've been at VA, I've learned a lot about human-centered design. And, you know, our views of primary care, as amazing as it is, tend to be a little bit practitioner driven.
Yeah.
This is how we think you ought to do this. Even patient-centered medical homes, if we'd asked patients, we wouldn't be calling them that.
Right.
Um, we have a different name at VA, but trust me, it is exactly the same.
Yeah.
Um, what is it that you need? And frankly, when should you get to skip primary care? You know, if you're a healthy guy,
Mhm.
age 40, say, and what you have is a knee problem, what are we making you stop here first? You know,
Mhm.
because it's our model. Now, that's not the only part of healthcare where we do that, but
Mhm.
still,
Yeah. Yeah. Well, important. I mean, honestly, we continue to wrestle with that on our day-to-day basis now at
yeah.
AHRQ. Is how do we bring patient their voice into the mix? And we're trying really hard to do that. But
Yeah. And, you know, when I gave you the example of having people on the task force,
yeah.
you know, one of the challenges is that frankly, the people who are on the task force work very, very hard, but they're mostly subsidized by their institutions to log all this time on phone calls and so on and so forth, which is good for the nation and really awesome. Um, but if you're asking people who have day jobs or not,
Yeah.
you know, what's the value of their time and, you know, how do you compensate for that and so forth. So that's why I say the timing was not so great.
Yeah. No, that makes perfect sense. And I think it's still a challenge today, but important too.
Yeah.
So, well, thank you for raising that one. I mean, and it's sort of, I mentioned earlier, we're actually gathering together a bunch of people actually to celebrate 30 years of work. I think the very first meeting at ACPAR in primary care was March 1990.
I
Um,
remember that. Yes.
yeah, I can imagine you did. And I think Paul Nutting led some of that work early on. And if you had to give some advice to the people we're gathering together about what should be on the research agenda for the 20s, do you have some guidance you might offer to folks to think about? What do we really need to consider to make sure we don't miss?
Well, I think for this pandemic, um, we have a huge opportunity to figure out. how do we keep some of the changes we had to make, right? We went virtual fast to protect patients and clinicians and so forth. But let's be honest, some of that really worked well. You know, early on, I remember advising a couple of family members who said, gosh, I have a thing on my skin. What should I do? Should I call the doctor? And I said, no, take a picture, call the office and email it. And sure enough, you know, then it was done. Now, why would anyone want to march back from that?
Yeah.
Right?
Great
So
question.
I think that we need to be pretty focused on that. I think we also need to figure out for all the people who didn't come in,
Mm,
um, who do we miss?
mm,
Right?
mhm.
Now, you know, if I were queen of all healthcare, right, I would want people to be looking at, particularly where they have electronic data, um, people with various chronic conditions. So, for example, 25% of veterans have diabetes. That's a lot.
Mm,
You know, we've got 9 million people enrolled in our system, and we serve about 6 million active users of our healthcare. And, but they don't all need to come in like next week because we're catching up on what we missed.
right.
But we ought to be able to figure out who needs the most help.
Mhm, mhm.
And how do we get proactive and reach out to them? Another thing that I think is going to be really important, a big part of primary care is motivating people to
Mm,
change their behavior.
mhm,
It's hard, you
mhm.
know, saying it's pretty easy,
Right.
you know? Reminds me of the time I heard a chief resident in Richmond say, really great to see you, Mrs. So-and-so. Just remember, quit smoking and lose weight. See you in 6 months. And he was actually serious, a very upbeat guy. And I almost hit the floor, both laughing and like deeply chagrined. Like, are you kidding me?
That'd be
um, and I don't think the doctor or the clinician, whatever discipline,
yeah.
needs to be doing all that personally. Clinicians own a very teachable moment, and you can't let that go.
Mhm,
But the ongoing work, I think, could be handled by coaches. What do they look like, right? We're
yeah.
working with a company now that helps people with diabetes, and what they have are doctor coach dyads. Let me just tell you who's doing the work, the coaches,
Yeah.
right? And I'll tell you what, the veterans who signed up for this, they love it.
Wow.
They love it. So
Terrific.
I think we need to learn much, much more about that space. We need to learn about what works well in telehealth and virtual care and what really doesn't. I mean, sort of like the rest of our working lives right now. And those would be top priorities for me. And the other would be, how do we bring the expertise in primary care to build on to bear on all the health equity issues that we're seeing?
Ooh.
Right? I mean, we know, in my favorite recent study from AHRQ is not about clinical care. It's about what are the social risk factors?
Mhm,
People who work with the medical expenditure panel survey, right?
mhm,
And guess what? It turns out that a much higher proportion of Blacks live in households with at least one healthcare worker.
mhm.
And I'm using that term very broadly, as they did. And about 2/3 of Latinos actually do not have an option that means working at home.
Mhm.
That's just not on the table. That's on top of issues around, is social distancing even practical where you live? I'm the oldest of 7, and let me tell you, my entire growing up life, social distancing would not really have been feasible.
So, hi everybody, Helen Burston, CEO of the Council of Medical Specialty Societies. So 45 specialty societies across the House of Medicine, primary care and specialty medicine, really all together, working together to improve quality, improve education, professionalism. And a long history in healthcare quality and disparity since my days at AHRQ and before that at the Brigham Women's Hospital in Boston. And I think if I was really reflecting on our most significant accomplishments in primary care research at AHRQ, I would have to say it's the work we did around the primary care practice-based research networks,
Mm,
which was very much the brainchild of David Lanier. But I think the ability to really put clinicians into a spot where they could both contribute to the research, but also drive it. Like, these are the important clinical questions. I see this every day. This is what I need to better understand. Engaging patients was so powerful. So I think that was, to me, the number one issue. I think the second one, and at the time we didn't even realize the significance of it, was the amount of work we did on ambulatory safety, and including the launch of the health IT portfolio for AHRQ, where we did a lot of work on looking at how electronic health records and decision support, reminders, et cetera, could really improve patient care, improve preventive services. For example, we funded some amazing work. I look back on it, uh, blanking on his name now, of course. Project Echo was
Yes.
Sanjeev Arora was funded by us for his first grant, came out of Primary Care Research Center at AHRQ so many years ago, and that has just taken off in a way that, at the time, I remember us talking about, wow, just a grant in New Mexico focused on hepatitis B. But I think we could see what was so exciting about that opportunity, that there was just a unique opportunity to think bigger than the way we've transmitted information, the way we've taught. So I think Sanjeev is a great example of where technology was brought to bear to really drive both learning, education, and certainly improve outcomes, as he has demonstrated. And the second piece of that really is the work around electronic health records, clinical decision support. For example, people don't realize that we funded Farzad Mastashari's work in the New York City Health and Hospitals Corporation and all the community health center clinics that were adopting EHRs for the first time. So you look back at those very, very early building blocks that, people sometimes don't think about AHRQ having all that much money. But there's a great, I've always loved, for example, Emily's List. Those people don't realize Emily is actually an acronym, like everything else in the federal government, and it means early money is like yeast, which I always loved. So in many ways, I felt like AHRQ, and particularly our primary care portfolio, we were just yeast. We tried really hard to take innovative ideas of how to drive improvements and developments in primary care and primary care research, and really give people that leg up that they could then build it over time. But those things started because we could give people just a couple $100,000, so many years ago. So I think those are the two. I think the last one I would have to put in there is just all the work we did around prevention and really trying to make the connection between the work of the U.S. Preventive Services Task Force and how we actually drive improvements in preventive services. And there was just so much important work around reminders, colorectal cancer screening, and others that I think really, again, set a real precedent for what could be done in the context of primary care.
Well, that's terrific and great. All those are great highlights. Actually, one thing that you may or may not know, that just is make sure for people listening, the echo work used during COVID-19, pivotal.
Oh, I know very well. Yes.
Yeah. I mean, it just blows my mind, about how this work stuff as you sort of described hepatitis B in New Mexico, and now that's how we're reaching clinicians to help train them up on COVID-19. I mean,
I think the ability to just take what was new and innovative, both techniques in terms of research or interesting approaches using technology, we were able to sort of give some early money to, and we've seen them blossom in just some extraordinary ways.
Right. Very impressive. It's a great list. So the thing back is there something you really wished you could have done that you couldn't get to, either for policy reasons or resource reasons or other reasons? Was there something that, I wish I'd done that before when we'd had time or something?
Boy, I'm sure I had a long list at the time. It's hard to know in retrospect. I think it's a really good question. I think there's probably more work we could have done around ambulatory safety and medication safety way back when. We funded some very early work on that, but it was always the sense that so much of our early work in patient safety was hospital-based, and we all knew how much was outside the hospital. We knew it was the tip of the iceberg, and yet getting people to sort of take that early focus on the ambulatory care space was really a challenge. So I think that was one of the more difficult things, is how do we get people to recognize that? Some of the work we did, for example, around ambulatory CPOE was really important early on, CPOE in general, but really just trying to think about what you could do with decision support in the ambulatory context. Decision support still hasn't moved as far as I think all of us dreamed way back when, in spite of the fact that we did some remarkable things. I mean, John White and I did a meeting probably in the early 2000s. We brought together the HIT community and the guidelines community and said, you guys need to talk. Like, we should just be only building machine readable guidelines. And yet it was so early, people were like, who are these two crazy people? Where are they coming up with these nutty ideas? So, you know, again, sometimes the beauty of a place like AHRQ, and I often said that about AHRQ, is it felt like the gift of being in a think tank. Yeah. All right. There was not a lot of money, but there were really smart people who were willing to work with us, and we could just give out sometimes just a little bit of money. I wish we had more, but at least I think we seeded just so many really important ideas out there. Yeah. But I do wish we had done more to push really hard on the ambulatory safety side, and particularly medication safety.
Well, it just, we're working on it. Actually, you'd be surprised that there's a meeting coming up on that, as you probably know, very soon. So it hasn't gone away, and people still recognize it's important.
I wish it would, but yes.
Yeah. I mean, the other thing that I think people sometimes forget, though, is, you know, when you were there in the early 2000s, I mean, IOM report was 1999, right? I mean,
yes, just
people were still digesting that. So it just, no new thing before its time, I guess. But,
right, but at the same time, what a gift to be in a place when I remember, you know, John Eisenberg, so many of our mentors, for those of us who were there in that time period, you know, just walked up to me and said, hey, we have $50 million in health IT. Do you want to figure out how to spend it? Like, you know, those are those moments you sort of relish. And I remember us sitting there trying to think about how we could come up with the right acronyms, of course, you know, clinical informatics to promote patient safety and things like that. But in many ways, the patient safety report in particular, because I was there in that earlier time period, was such a seminal piece of work for AHRQ. And I think that, you know, going back to your earlier question, what do we wish we could have done? If we had a whole lot more money, we could have done so much more. And even though that was a heyday for AHRQ getting dollars, there was always so much more, particularly investigator-initiated research and ideas, that were just awfully hard to get to the top of the pay list, particularly on the primary care side. So it was always about resources. It was never about lack of ideas.
Yeah. That's not a bad problem to have if you think about it.
It's not a bad problem to have for a think tank. You're right. We had lots of ideas. I think we seeded a lot of really good work. I wish we could have done more.
Yeah, well, I appreciate that. Thank you for taking the time to reflect on those. And the last question I wanted to ask is, so we're bringing together about 50 people in a few short weeks to think about how to set up a research agenda around primary care research, you know, for the 20s. And now COVID, of course, has changed everything.
Everything.
Guidance for that, as that group of people comes together, are the things that you think about that we should really pay attention to, or say, don't forget to do this?
Yeah, no, it's a great question, Bob. I think first and foremost, and very much influenced by the pandemic, has been the shift to virtual care. And I think it has to get to the point where we don't think about things as that's telemedicine, that's, you know, in real life care. And I think a really important research agenda for the future is understanding how we better interdigitate just care, whether it's virtual or remote patient monitoring or in person. So I think there's a huge research agenda around understanding, given a person's needs, what setting is best for them, and recognizing that it can be very fluid. And ultimately, I think particularly if you have your clinician doing your virtual care and your clinician's team doing your personal care, what a transformation to be able to have that quick 15-minute chat when someone needs it, take away all the transportation issues for so many of our patients that are still such a burden. So I think this whole research agenda around how we ultimately look at care that combines virtual care and in-person care, and when is what is best. To add to that, I think the explosion of data that will be coming towards us from remote patient monitoring devices. We just had Bob Wachter at our annual meeting last week, and he was saying, you know, if I started having all that remote patient monitoring data just start flowing into all the primary care practices at UCSF, the docs would be like, what do I do with this? So I think we have to figure out, it's wonderful we're going to start getting these data in. We need to get these data, but we have to figure out a better strategy that uses AI, machine learning, whatever it is, to kind of cull through all that data and pull out the relevant information, I think is the second piece. I think the third piece is increasingly this idea of, actually I'll quote John Eisenberg again. John Eisenberg used to always say, patient safety is a team sport and the patient is on it. So I think the next generation also has to look at, particularly in this more virtual environment where patients will hopefully increasingly get their hands on their information in near real time and can really share their information with us, the whole open notes movement, et cetera, really thinking through how patients become part of whatever agenda we set going forward. It can't just be primary care. We've got to get patients at the table with us. From their perspective, how does care need to change? And I think that's been transformational. One of the person who spoke at our meeting, Donna Cryer, who's a patient who's now on our board, talked about portalitis, right? She's got like multiple medical conditions. From where she sits, it's crazy. She can't go to hospital system, doctor portals and get different data. So bringing, I think, the patient voice to the table in terms of setting the research agenda would be another one I would add. And the last one I would add, and probably not too surprisingly given my current role, is I worry sometimes when we are so singularly focused on primary care without thinking about how it really relates to the full ecosystem, what patients need.
Right.
So if I'm in primary care and I can't get a patient to a specialist, that's a problem,
Yeah.
right? They may really need to see that specialist. So I think avoiding having our blinders on, I think really ultimately thinking about how primary care fits into and often leads that overall fabric of care across settings and providers and clinicians and specialists, I think is going to be the important piece here. We've got to figure out, again, from the patient's perspective, where they go to get care and how that gets put together in a patient-centric view. And that's where I think we have more in common, as I've learned, certainly in this role, across specialties, in your world, also across disciplines. It isn't just MDs either, right? It's just this whole piece around understanding what we each bring to the table and respecting that collectively, and not hopefully getting to the point where it's not always about whose piece of the pie am I eating in terms of funding, but really thinking about, from a patient's point of view, what's the optimal flow of patient information? What's the optimal way I can get care? If I can get a virtual curbside consult, virtual consult with a clinic, with a specialist, how does that fit in? And then ultimately, as we think about the future of the way payment is going to change, how does all that fit into advanced payment models, where it's less about everything being about a visit and more about that whole continuum and the trajectory of care? And with that, I think comes this focus on, again, back to the patient, but the idea of getting much more focused on patient-reported outcomes flowing into practice as well. And how does it change the way you provide care? How does it change the way you interact with patients? If they're giving you what they think are their most important symptoms, how do we not, we have to make that a priority to address them. We've been talking, I help run these virtual tweet chats we've been doing on telemedicine. And we did one recently specifically on how do we bring in patient engagement and patient outcome reported data. And there's this concept of, you're sitting there waiting for your telemedicine visit and you're kind of in the digital waiting room. Why not make that a great opportunity to start collecting some of those data, or flipping the clinic and sharing with patients some of, here's a video you can watch about the issue we're going to talk about today. So I guess so many of these last comments are really about technology writ large. How does technology transform practice, primary care, the connection to specialties? But I think also, really importantly, if patients have technology and clinicians have technology and we're in more of this virtual environment, how do we take advantage of that so we both learn and thrive?
Yeah.
Started at AHRQ in January of 1993, right at the beginning of the first Clinton administration. Prior to that, I had been in academic family medicine. I was immediately before joining, I had been at Georgetown University as the director of the primary care division. And I have to say, after being residency director and medical director, I was completely burned out on the bureaucracies and the infighting politically and the academic politics that were involved. So I like to tell people that, yeah, I left this cushy job at Georgetown to come work at the federal government in order to get away from the bureaucracy and politics. And so there's usually a lot of head scratching that. But my first job at AHRQ was, at that time it was AHCPR, was in the forum, which one of the flagship programs of AHCPR was development of clinical practice guidelines. So what little research I was able to get done at Georgetown before I was completely inundated with bureaucratic needs was on low back pain. So I was made the action officer for AHRQ's clinical practice guideline on low back pain. And if there are any people historically know about it, that guideline was in the center of the storm that nearly resulted in the agency being dissolved as a result of dispute about what clinical practice guidelines were and how they were developed and how they were to be used. So not too long after that storm passed and we survived, I accepted an invitation from Carolyn Clancy to join the Center for Primary Care Research, which I did. And after a couple of delightful years working with Carolyn, she was promoted or in some way took a job as the director of the Center for Outcomes Research. And John Eisenberg, who was the director of the agency by that time, came to me and said, "Are you interested at all in being the director of primary care now that Carolyn's moving up?" I said, "Oh no, I've been there. I will be happy to be acting director while you start a search for permanent director." So it ended up being a prolonged search. And finally in 2000, Helen Burston was hired. I became her deputy director for the time that she was there. Then in 2007, Helen left. I again became acting director until finally David Myers was hired to take over the center. So that's the sort of trajectory of my time at AHRQ.
What a terrific story, though. And I was not aware of the back pain side of it too, and I know that is a pivotal point in the AHRQ AHRQ history.
Right.
So thank you for sharing that. Well, terrific. And during your time then at the Center for Primary Care, working on primary care issues, what would you, reflecting back, think about? What was the most significant accomplishment you thought, if you had to pick one, or maybe a couple, that you had while you were at primary care, working primary care at AHRQ?
Yeah, well, that's a pretty easy question for me to answer, in that my work with having the agency support primary care practice-based research networks began in 1999. And so for well more than 10 years while I was at AHRQ before I retired, that's what my efforts were directed toward. So you said you have an interest in history, and for people who have been in primary care research for a long time, predating 1999, a lot of this story is old hat to them, but I assume there will be some newer researchers who may be interested as well as how this all evolved at AHRQ. And so maybe I could take just a little while to talk about that, if that
Please.
works.
That'd be terrific.
So looking back on it, it seems to me that there were a number of factors that sort of converged in 1999 and came together very harmoniously. By that time, we had weathered that our near-death experience, as we call it, from the mid-90s, or Carolyn Clancy loves to say, our year of living dangerously. And so our budget, while it had been slashed initially, was creeping back up. So there were some funds available to do different things. John Eisenberg, as I said, was the director of the agency by that time. And John was not only a brilliant clinician and researcher, but he also was a very talented politician who saw quickly that it was not going to be enough for the agency to simply trot out, we gave these grants, we published these papers, and expect that Congress was going to be receptive to us, even for the small amount of money that, relatively speaking, that they were giving us. So John became very interested in the issue of quality, was able to get the agency reauthorized by a new name, AHRQ, that included the word quality. And it was very clear that our audience was not just health services researchers, but there were clinicians, there were patients, there were health policy people, a broad spectrum of audiences. And John, as a primary care researcher himself and a primary care clinician, knew that primary care had to be in the mix there. So that was one important element that was in place by that time. For myself, I had become interested in PBRNs from the very onset. I actually was at the NAPCRAG meeting where there was a huge discussion about whether they were going to devote money to form one of the first and one of the major networks in family medicine, which is called ASPEN, the Ambulatory Sentinel Practice Networks, and had followed with great interest what was going on in the network. Ironically, in December of 1999, that network was dissolved at the same time we were getting because of financial problems that they were having. With the little research time that I had at Georgetown, I had, with my interest in PBRNs, established a fledgling PBRN at Georgetown. And we had some success. We got a couple of studies done, had a couple of papers published. And so I knew the excitement and the potential of PBRNs, but I also was very clear about the challenges that faced any institution trying to start a PBRN, including recruiting and retention of clinicians, issues with data collection and quality, IRB issues, the list goes on, not to mention funding that's involved in that. So that was the sort of perspective I was looking at. And I was thinking, what can we do with PBRNs with AHRQ, given limited resources? And at that time, as far as we knew, the only published reports about PBRNs were that there were maybe about 24 of these across the country at the time. I knew maybe 10 of those networks and was not familiar with the other ones. So we were thinking, okay, well, so there may not be that many networks out there that are receptive. What if we did something small scale to begin with, given the limited resources the agency had, but that would benefit not only those 24 that we knew about, but maybe there were out there some other groups that were ready to coalesce into a network, and all they needed was a little nudge, a little seed money. So I came up with the idea and presented to John of doing planning grants. And so it was a little risky in that, you know, at the end of this time, we knew there wouldn't be any super concrete things to show, no research to show or necessarily any improvements, but it would allow us to start developing this new mechanism. So John loved the idea. Of course, he was 3 steps ahead of me, thinking in terms of them as being quality, places which we could monitor and improve quality because we were engaging with actual clinicians who were there. So we decided on the amount of money that could be devoted to it, and it worked out that it was a very small amount of money that we were going to be able to offer each network, around $75,000. Well, my colleagues at NIH sort of laughed, you know, because this amount of money is not even decimal dust to them. They said, who in the world is going to write a grant application for $75,000? And how would you ever get that study section to look at that to begin with? So what we did was to sort of bite the bullet and say, we're going to send this out. And I was really worried that we were going to have like maybe a dozen applications from the usual suspects, and this was really going to be kind of a futile effort here. Instead, calls started pouring in as soon as the solicitation went out. And I said, oh, what we did was to say there were 5 areas that they had to tell us where they were and where, with some planning money, they could advance their network. So we were looking for groups that were established as well as those that were just beginning. And we started getting calls. I was thinking, well, maybe this will be all right. Well, by the time we got around to having the day that we accounted for the number of applications, it were in the hundreds that we got. And I was saying, what? And some wonderful stories. I mean, when you look at these applications, it's clear huge diversity in the expertise and experience of these groups in writing grant applications. Some of them, you know, look like Barbara Starfield had written them, that beautifully done, polished. Others, clearly, this is probably the first research grant application they had ever written. My favorite story is of a researcher who will go unnamed, who knew not a lot about research, but he knew it was important and he knew it needed to be done in primary care. And I think the grant applications were due at 5 o'clock on a Friday. By mid-morning on Thursday, it was pretty clear that he was not going to be able to have this finished to put in the mail because we didn't have electronic applications at that time. So the paper had to be arrived at the grant center before 5 o'clock or it wasn't counted at all. So what he did was to book an airplane to Reagan National Airport, worked all day that Thursday through the night with his assistants, got on board the plane, which landed at about 3:30, got caught in traffic in a cab, arrived at 4:45 and came rushing in, fortunately not having a heart attack, but I'm sure pretty close to it, putting these applications on the desk, and they were considered. So when we saw this, we thought, wow, what are we going to do with this? And we were fortunate enough to be able to put together a terrific study section who clearly understood that we were looking not for people who in the next year or two necessarily were going to be great researchers, but the potential of these, both from where they were geographically located, their institutional support, what other resources they could pull in, had the potential, and particularly the patient population they served, had the potential to produce great research. And so we were able to come up with a group of very, very excited researchers, some who this was the first grant primary care had ever received in their institutions. And so that in itself was a shot in the arm to many of these to keep going. But we wanted to look upon this as a learning opportunity. So we brought all representatives from all these networks together so that they could not feel like they were the Lone Ranger operating out on the plains, but there were other groups that were there. We tried to arrange a sort of big brother, big sisters system in which more experienced networks worked as mentors for the younger networks, and they could call them and say, gee, I've got this problem with an IRB, what should I do? We were able to extend that in the years that came while developing the Resource Center, so that we had a professional group who was there and was actually paid to do that job, to provide that type of help, particularly technological help and data collection help, IRB issues. And eventually we were able to see that there were a group of networks that were really at a stage where they could go much further, and started having contracts with them and for rapid cycle research they were able to do by contract and task orders. So it did not have to go through study section, could be initiated quickly, the work could be done, there were deliverables that they needed to have for the agency. So I certainly think, looking back, that was the most important thing that I was able to help accomplish. Of course, didn't do it by myself, but was able to help accomplish, and delighted to see that from the 24 networks that we started out, I looked at, I think the most recent numbers there are about 175 networks across the country in primary care that meet our definition.
Absolutely. And as you know, I think you talked to at least one or two of our summer fellows too recently, and who were trying to update some of that information. And it is truly something that has lived on and grown tremendously, I think, since you put that first seed money in.
Right.
Well, that's great. And thank you for telling that story, because that's important. There's so many important lessons in what you talked there about that we can use as we think about the future. So thank you for that. But I also want to sort of say, so thinking back, is there one thing that you wish you could have done during that time you were with AHRQ and AHRQ that maybe you weren't able to do for whatever reason, resources, people, time, but something that you wish you had done but didn't?
Well, most people that know me understand that I'm not a really high-tech person. In fact, the term Luddite has been used many times to describe me. But nonetheless, I think I've really appreciated from the very beginning the importance of electronically collected and aggregated data. And that until primary care can get to a point where they can do this rather seamlessly, we're never going to be able to achieve what we could do. So I think in the very first planning grants, one of the requirements was that you tell us how are you going to be able to enter data electronically, aggregate it, and report it out. And that was a real challenge for some of these people. I got some pushback from a number of networks. Says, we've been doing these card studies for a long time. They work just fine. They don't cost much money, blah, 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 blah. I said, well, that's fine. You can continue doing, but if you're going to be working with us, you need to figure out how you can move on to the next step. So pretty soon after that, electronic health records came into being. I say this all as a sort of a preface to what I was dreaming of at that time. And that would be that at some point, there would be the capability of collecting and aggregating from multiple practices, maybe through mechanisms of PBRNs, maybe from a selected group of sentinel practices, all the data that's collected in a continuous and ongoing way from primary care that we could tap into historically. You could maybe add data points to that you wanted to collect for future studies. And when you think back, the seminal work that's been done in primary care back in the 70s was done looking at large databases. Look at Barbara Starfield's brilliant work that she did, looking at Medicare claims data, and now the MEP surveys have been a source of really important information. I mean, it's not the only type of research, but it can point the direction and can help you begin to understand some of the things that you have hunches for. Is there some evidence there might be there? But how wonderful it would be to have actual day-to-day collection of data. Now, the challenges, of course, are enormous. I don't need to go into that in terms of confidentiality, not to mention who's going to fund this and how it's going to be sustained over a long period of time. But it really seems to me clear that until we reach that level of sophistication, we're probably not going to be able to do the type of work we'd like to do. With relationship to PBRNs and the importance of these ongoing data collection, people may not know this, but I was an English major in undergraduate school and have been writing poetry since I was a teenager. And that's what I'm spending a lot of my time doing these. So I say that as a way of letting you know that I'm a real sucker for metaphors. And so one of the big metaphors that John Eisenberg issued into was this idea of a national dashboard, where we can look at the dashboard and at any point in time say things about the quality of care that's being delivered, the rate of immunizations, the rate of uptake of preventive services, morbidity and mortality across the country. First heard that matter, I thought we need to have something up there about primary care. You know, that we need to be able to tell in an ongoing way what's going on with primary care. And so PBRNs get into this because of another metaphor that I will attribute to Larry Green, who, I don't know if Larry will be attending the conference, but he has been an extraordinary supporter and visionary in terms of primary care research in the country. And when, at least in one of his papers referring to PBRNs, Larry used the term of PBRNs as reusable rockets. So immediately you get that the metaphor captures what we're talking about here. You don't have to rebuild the whole structure for this. You got them and you can use them over again. Well, I would love to take that metaphor one step forward and think instead about a data collection system that maybe involves PBRNs or other practices as more of a space station that's continually in orbit around the United States, able to look at what's going on, to provide reports back for that. And that works for me. And that would be one of the things that I would have loved to have seen, certainly never happened. And there are enough challenges, it's going to be difficult to ever be able to do that, but I wouldn't say that it's impossible.
Yeah. Great metaphors too. Really, they're easy to capture and think about how we might be able, well, how we do it is going to be tricky, but definitely what to do sounds terrific. Yeah. Well, good. Well, so last question is people are going to be gathering, and do you have any advice or guidance you give to participants? This is as we think about a primary care research agenda for the future. What kinds of things do you think should we be thinking about?
Well, let me sort of give you a 10,000 or 100,000 mile view of this in terms of primary care research. I think I can say without this being a blemish on AHRQ that when people come to work for AHRQ, particularly in primary care, you quickly learn that there have to be some limitations on what you can hope for. I mean, I've already, in the things that I've just talked about, I said, well, we had to worry about this, we had to worry about this, we had to worry about this. So you start scaling down the scope in which the ideas that you allow yourself to entertain. In fact, it occurred to me just now that this whole idea of this massive collection of research data from across primary care practices, I don't think I ever discussed that once with my colleagues, because it was just like, that's not going to happen. Why waste our time thinking about it? And the other memory is that, you know, as obsessed as we were with having very little money to spend and on a yearly basis, and every year having to go through this again of finding out what our funding level was going to be and what we're going to be able to think about. The thing that probably terrified us most was when health services researchers came up with this slogan of billionize AHRQ. And we thought, oh my God, what would we possibly do if we got $1 billion? Because we don't think about it in terms of that large a scale of getting things done. And how would you ever get the money out the door, et cetera, et cetera. Mm-hmm. So big thinking, there's sort of, I won't call it aversion therapy, but it's something kind of close to that in the agency that you undergo when you stay there a long time. And so I would really hope that the people who are attending this conference haven't been subjected to that. They have carte blanche to think about pie in the sky things that may sound ridiculous, but we may be able to find among those a few things that really, really make a difference in both research and the delivery of primary care. So that would be my advice.